the so-called bad outcomes. And you gotta understand this. I think we really need to think about this problem. We concentrate in the good outcomes, 0 to 2. But in reality, what matters the most is avoiding catastrophic outcomes. Let's do the following exercise. I want you to think about 6 people that you love. One is gonna have an MRS of 6, another one 5, another one 4, 3, 2, 1. God is gonna give you 1 point for you to apply to any of these 6 people you love equally. Where are you gonna put that 1 point? Just think about that. Are you going to get that MRS of 1 and make it a 0? And then leave the person that has the MRS of 5 a 5? Where are you gonna put that 1 point? Are you going to make the 3 a 2? I can tell you where most people are gonna put their points, because this has been looked at different societies. Most people, you're not gonna change a 6 to a 5. It's a terrible thing to be bad reading content. But you're gonna change a 5 to a 4 or a 4 to a 3. As opposed to go 2 to 3 or 2 to 1. So the so-called excellent and good outcomes, it's not really what you all care about. And how that is fair with the way you think about stroke. Because if I gave you 1 point to save that family member, you're not putting towards making them excellent or good outcomes. You are changing the catastrophic outcomes. So you're looking at this in the wrong way. Then you say, well, you treat these people and a lot of these 4 or 5s, they're gonna die in 1 year. It's not true. 11% increased death in Saletto, 0% in tension. So these people stay alive with miserable lives. If they are a 5, they're gonna live like a 5 for another year. Okay. If they are a 4 for another year. And then in the next few minutes, I just want to try to walk over why this works. First thing that you need to understand is not about shrinking the size of the infarct. The infarct is large, okay? It can get small. If it's really large, it can. And you know that from HERMS, only 12% of the benefit of thrombectomy is shrinking infarcts. So there is more than quantity, there is location of the infarct. We know that the higher, more posterior areas of the aspects carry higher utility in terms of eloquence. We talk about the fake horse. This is what we learn. You're stuck with this idea of penumbral rescue, right? You stop the infarct growth. You stop the green from becoming red. And that's true, you do that, okay? But if you look at, you now have several papers about this, even patients that don't have a mismatch, they benefit, right? So first of all, this whole idea of using mismatch is misleading them if it doesn't really change the chances of benefiting. But then it also points that this idea that it's only the size, the quantity of the infarct that matters is wrong. There is a new dimension, which is the quality of the infarct, not only the quantity. You have to understand this. We rescue the penumbra, but you also rescue the core. You stop the infarct maturation. Stroke is not binary. It's not 0 or 1 stroke, no stroke. There are shades of gray as you see here. It's important that you understand this concept, that you don't only treat the neurons, you're treating the whole neurovascular unit, and the vulnerability of the different cell elements to ischemia varies, right? The white matter is a lot more resilient than the gray matter. The metabolic rate is lower, okay? And white matter is very, very important in motor recovery. So it's important that you understand that it doesn't go from normal to pannecrosis like this. It walks through that process. And if you prevent the light gray to become black, it's a big time benefit there. And you know this from basic science. And let me just show you quickly two cases. ICA occlusion, high NIH. Treat the patient, have an ACA, MCA prone, treat, reperfuse. Here is the scan, large infarct. Not saying it's not a large infarct, but look at the pattern. It's mostly gray matter with the high metabolic rate. 6 months later, I don't have a black hole. I have this infarct, but there is still brain there. There's still this scaffold. Very different than this patient that came too late and we didn't treat. That has a black hole encephalomalacia. First patient, MRS3. Second patient, MRS4. Even though this infarct is smaller, right? So, important to understand, it's not only normal brain and that brain. There is something in between the normal and the dead, right? Very much like we talk about the stunned brain, the sleeping brain. We have the zombie brain between alive and dead. There is the zombie brain, and the zombie brain will virtually make the walking dead. Okay? This may be the difference between the MRS of 4-5 versus the MRS of 3. Okay? It's the zombie brain. And then you say, how this is all cool and all that, but prove this to me. Well, select you. Let's look at final infarct volume. Was actually bigger in the thrombectomy group at 170 cc's than in the control group, 168 cc's. So it's 2 cc's bigger. So if it's not the size, and not the quantity, it's the quality, right, that made the difference. Here is tension again, showing it's not a big difference in terms of volumes. Other thing that happens is, as you rescue the neurovascular unit, maybe neurons died, but you still have astrocytes, pericytes, endothelial cells. You prevent cerebral edema. So there is a potential benefit there. Unless you have panecrosis, that now when you reperfuse, you can actually have more cerebral edema. There are many other things that happen in terms of cytoprotection and regeneration that we just don't understand yet, but they drive a benefit. Another important concept is that it's not only quantity, quality, location. Also, the quality of the residual brain matters. So the concept of brain frailty, when you revise this simple penumbra core concept, you know the core, you know the penumbra, there is this tradition, but now you have to understand there is a volume there and there is a density, right, within the core. How dense that core is, how complete it is. But there is another important variable, which is the functional reserve, the residual brain. When I have an injury, the normal brain will take over for that injury site, right? And that's the idea of brain frailty. And you have to introduce the concepts of chronological age versus biological age, but then brain age. Brain age is what matters the most, okay? And it was amazing to me to see the large core trials. This was surprising, okay? Age wasn't a treatment effect modifier in most of these trials. This was surprising to me until we look at our data in Brazil, which I suspect it's the same data that I saw at the 115, the People's Hospital. Because we are a lot more reflective of what happens in the population. This is the impact of socioeconomics on outcomes, brain frailty, higher case fatality. This is Rio de Janeiro in my country, Brazil, I think similar to Vietnam. There are two realities here, right? You have the private sector, rich people, good health insurance, versus the people who are more vulnerable socioeconomically and not in the public sector. We published this paper that showed great benefit of thrombectomy in this population, despite having almost 1.5 to 2.5 times higher mortality than other trials. the treatment effect was maintained. In fact, we had the highest benefit in terms of avoiding catastrophic outcomes of any trial. So thrombectomy works very, very well in the public healthcare system of the developing countries, okay? But it's cost effective. This led actually to the implementation of thrombectomy in Brazil. But what I want to show you here is this age paradox. This is HERPS. Age straight up. You see there 18 going all the way to 80. As I go up in age, numerically, what happens is that my treatment effect gets higher. Because old people do worse than the young people with thrombectomy, but they do a lot worse without thrombectomy, so the treatment effect size is bigger in older people. That is the same thing in the Aurora nuns, but when we went to Brazil, patients older than 70 actually didn't have a benefit in their early window and were potentially harmed in the late window. And then you go like, why? You may say, how thrombectomy in Brazil is bad, you guys just don't know how to do it. And I would point you to that number there, 4.3. That's the highest treatment effect size ever seen by any age in thrombectomy, okay? So actually it works very well in Brazil up to a certain age. But remember what you talk about. Think about brain age, and we believe that brain atrophy, leukocytosis, white matter disease, brain frailty is what was driving that. There is a lot of work on that. This is a nice paper from Escape looking at brain frailty and clinical frailty. This is my dad. He's 88 years old. He has 2 cancers, severe sarcopenia, on chemotherapy. He works every day, okay? Terrible physical frailty. If my dad has a stroke and comes in a stretcher at age 88, many of you would say, I'm not treating this man. He's 88, he has 2 cancers, right? He's a doctor who works every day at the age of 88. Don't judge people. Try to understand how they function, right? Very, very important. And you know what really matters, even though the composite of physical and brain frailty explains the 100% of the relationship between treatment and outcome, guess what explains almost everything? Brain frailty, right? So it's all about the brain. So that little doctor with cancer and sarcopenia, if he has a good brain, he deserves a shot, okay? And when you look at resilience, you actually realize that after you adjust for leukocytosis, old lichens, brain frailty, age loses its effect on outcomes. So it's not about age, it's about leukocytosis. So you're wrapping up here. Let's just talk about MRS for a moment. You say MRS greater than 2, I'm not gonna treat. Not all MRS greater than 2, it's equal to brain frailty. Understand the reason for the number, don't treat the number. Orthopedic conditions versus neurocognitive conditions versus neuromuscular conditions, very different. Would you rather treat a 64-year-old with early dementia and MRS of 2, or an older patient, 84, with a higher MRS of 3, but from an orthopedic problem? I would go with the older patient with an orthopedic problem, even though the MRS is high. Understand the number, okay? And I like asking this question, would you ever treat a patient with MRS of 4? Most people say, no, that's what I trace my life. Well, would you treat this gentleman if you were alive? Right? I think most people would agree to treat Stephen Hawking if he was alive. Why? Because even though he had an MRS of 4, he was the anti-brain frailty model, right? So it's all about the brain. It's not about physical frailty. It's brain frailty. We need to understand that. So you need to change your mindset. We live in this reality of strokeophobia. We need in doubt, treat and ask questions later. That's what cardiologists do, even though the mortality in cardiac shock is 40%. That's what intensivists do, even though the mortality in septic shock is 40%. Trauma, they do everything, ask questions later. Don't want to talk about cost effectiveness? Talk to an oncologist, please. Understand this, EVT for small to moderate anterior circulation strokes, it's not a life-saving procedure. Don't say that, that's not correct. It's only a disability-sparing procedure. That actually has a bigger impact. Let me explain why. The reason is, if you don't treat STEMI, sepsis, trauma, cancer, the patients will die. The family cries, and it's sad. If you don't treat a stroke, mortality 20%, maybe up to 40% in these mega sizable strokes. Patient stays alive, but with a higher degree of disability. Let's look at the government. Patient dies, not spending money with that patient anymore. Patient stays alive, but with a higher degree of disability. Huge socioeconomic impact, huge. So if anything, this is the disease that should have the most aggressive approach in terms of socioeconomic impact. We should be thinking about strokes like a shock, cardiogenic shock, septic shock. We treat first, you ask questions later, right? Maybe the problem is there is no pain, there is no drama, tubes, blood. Maybe we should change the name of the entity from large stroke for cerebroischemic shock, because it's a shock. It must be treated aggressive, just like our other shocks. Here is precision medicine. I think these are the things that should make you understand what the prognosis is gonna be. Not the treatment effect, prognosis, okay? And then you can get all the information about poor prognosis and put in an algorithm like this with the understanding that these are your best guesses. You're not super precise, but as you are in an economic setting like United States, favorable is one algorithm. Like in the public healthcare system of my country, Brazil, should be a different one, perhaps in Vietnam the same. Large strokes, very poor prognosis, brain failed, old, large. I think should go straight to palliative care CMO. I mean, people have the right to die as well. Sometimes it's just too much. But if you're in a favorable economic setting, you may want to give it a shot. Ask the family, is an MRS 324 acceptable to you? If they say yes, treat and hope for the best. That's our way. If they say no, make sure you tell them that you're gonna make the patient CMO, right? Because not treating and leaving that patient alive and providing critical care and all those other things is the worst mistake, because now the patient will be alive with worse outcomes. So you should tell them that if you are not going to agree to palliative care, let's treat and hope for the best. With that, I conclude. Thank you very much for your attention.